I think the problem in the Middle East in particular is it's a very specific problem because the patient population is a specific patient population. The one we work with are victims of conflict very often. So it's people that were victims of bombing, shootings. They got operated at home first or in their country, treated with a couple of courses of antibiotics, some surgery. It doesn't work, and they end up in MSF projects with chronic wounds infected with multi-drug resistant pathogens. And so we did develop specific activities, surgical activities. We also, and this is I think also a very important thing, we increased access to microbiology because stewardship is one component of the battle against ABR. But you also need data about the resistance of your pathogens. And so what we specifically try to do in the Middle East is increase access to microbiology. So we're setting up different microbiology laboratories, actually. This is one of the possible actions, of course. I think another one, an important one, also a difficult one, is behavior change. Doctors, medical staff, I think have their practices and attitudes, and I think a lot of the work, important work to be done, is behavior change. It's a shift in the way people think about some diseases, antibiotics, and I think this is also we need to work on quite a lot, not only in the Middle East, in other settings as well. I hope the impact will, first of all, be that we document the problem. That's one thing. But I think what helps as well when we do these surveys and we use the tools is that we create some awareness among our people as well. Because I think in many of our projects, awareness about the problem might be quite limited. And I think using these tools and documenting the problem makes people aware of the extent of the problem. Because if you don't document it, you don't see it. I think a first step is, our first opportunity of this tool is to create awareness among our staff in our projects.